Okay, so let's start talking about abdominal x-rays. Now, I'm going to introduce my system to you for how to analyze abdominal x-rays. Now, there'll be similar systems you'll have come across for chest x-rays, which may be based on compartment or anatomical structure, such as working from out in or working from the center outwards. Or it may be a letter-based system, such as the ABCD approach. So I came up with this for abdominal x-rays, which I think covers everything you need to look at and know about an abdominal x-ray. And also I think is fairly easy to remember because it's abdo x. Okay. So we're going to go through each one of those, and we're going to start with A, which is for air. But instead of an abdominal x-ray, the first one I'm going to show you, the first image, is a chest x-ray. And the reason for that is because traditionally, when people attended emergency departments and there was a query about pneumoperitoneum, they would get two radiographs acquired together, an erect chest x-ray and an abdominal x-ray. And this is I'm talking about more than 10 years ago. And the idea is that an erect chest x-ray allows the air within the abdominal cavity to rise and kind of float underneath the diaphragm. And so you'd be able to visualize that by seeing this difference in density between the air in the lung, and then you've got the soft tissue of the diaphragm and then the air below. And so that's a pneumoperitoneum. And that is far more sensitive than the accompanying abdominal radiograph, which those patients would also have. So you'd be able to pick up the free air much more easily on erect chest x-ray. Okay, so when we're thinking about air, this is the reason I'm showing you the chest x-ray, because actually it's more sensitive than an abdominal x-ray. But actually, fast forward to 2022, and really we shouldn't be doing these at all, because the test of choice for picking up pneumoperitoneum is an abdominal CT. So really, ED shouldn't be doing these anymore, if they are. Now, there's just an important thing to be aware of that is often a mistake made when people interpret chest x-rays for pneumoperitoneum, which is Kyler-Ditty's sign of a pseudo pneumoperitoneum. Okay, so Kyler-Ditty described this, and it's essentially when you've got air which is within the right upper quadrant beneath the right hemidiaphragm, between the diaphragm and the liver, but it's not free air, it's air which is actually within bowel loops. Which has interposed itself. These bowel loops have interposed themselves between the surface of the liver and the diaphragm. So this is not free air, this is normal luminal air, but sometimes it can be mistaken for pneumoperitoneum. So this is a pseudo pneumoperitoneum. So let's move on to actual abdominal radiographs, proper abdominal radiographs. So it's very hard to find a good example of an abdominal radiograph where there is some subtle pneumoperitoneum. That we don't really have many of them. So the ones that I'm going to show you are really glaringly obvious examples. And if I ever find myself questioning, oh, is there or isn't there pneumoperitoneum, honestly, just stop and get a CT. That's the best thing to do. But anyway, here is what we do see. So the first sign I want you to know about is Wriggler's sign. Now, Wriggler's sign is when you see the wall of the bowel very crispy and clearly defined, as you can see here. And the reason why you should not see that is because X-ray is all about density differences, right? So you should have air within the lumen of the bowel, and then the bowel wall, and then all the kind of other intra-abdominal soft tissue adjacent to the bowel wall all blends into one. So you can't really tell where the bowel wall begins and ends. But when you've got pneumoperitoneum, you've got luminal gas, soft tissue of the bowel wall, and then extraluminal gas. So you've got this density difference, and that allows you to see the bowel wall very crisply and clearly defined. That's Wriggler's sign. The other thing to be aware of is when you get these very either linear or triangular shaped lucencies that you can't place within a lumen of bowel. They don't conform to a normal bowel pattern, and that's known as the telltale triangle sign of pneumoperitoneum. So here we've got a couple of signs of pneumoperitoneum. So that's Wriggler's sign. And we may come across Wriggler later during this session. So here is another example of Wriggler's sign, much more florid, much more obvious. So everywhere you look, you can see the bowel wall is defined really crisply and clearly. Can you just see over here? Should not be able to define it so easily. Also, I mentioned those little triangles. So here we've got a little seagull shaped area of lucency. Then here, this is a more linear area, which cannot be placed within any particular part of the bowel. And so that's free air. And the other thing you see here is, you see how the bowel loops are very distended. So I imagine what this is a complication of small bowel obstruction, the complication being perforation, and then you've got the pneumoperitoneum. Now, you will all have heard of tension pneumothorax. There is an entity known as tension pneumoperitoneum, which is incredibly rare. Here is one example. And essentially, it's similar to what you get with tension pneumothorax, which is one-way inlet of air into the peritoneal space, but it's got nowhere to go, so it then builds up the tension. So the kinds of scenarios where you might find that happening is, say, a colonoscopy, where they're doing a full thickness biopsy, maybe doing an endoscopic resection. You've got all the gas being pumped in because of the colonoscopy, and then once you've got a full thickness perforation, that gas is going into the peritoneal space, but it's not then being allowed to exit. So what you'll see is that the diaphragm are tented up, the hemidiaphragms are tented up, and the abdominal wall is pushed out, and all the organs are pushed in centrally into the abdominal cavity. All right, now we've talked about air in the peritoneal space. Remember that in the abdomen you've also got the retroperitoneal or the extraperitoneal compartments. And air in those spaces looks very different, because unlike the peritoneal space, which can open up like a balloon, remember that the retroperitoneal and extraperitoneal tissues are tightly bound by fascial planes and lots of different types of tissue. So when you have air within those areas, rather than showing up as a balloon of air, what you'll see is this kind of wispy pattern where air is dissecting between the tissue planes. And so as those different layers are lifted up, then rather than seeing a big blob of air, you'll see wispy, linear, curvilinear, soft tissue lines and bubbles of gas around it. Okay, so here we've got all of this extra and retroperitoneal air within the right side of the retroperitoneum. This over here, this circular structure, this ring, this is a stoma bag. So here is, if we go back to that, you got lots of gas on the right side and you got some gas on the left side. Now just remember to go away and think about the causes of a pneumoretroperitoneum. So we're thinking about all the retroperitoneal bits of bowel, so parts of the duodenum, also sometimes with sigmoid perforations, rather than causing pneumoperitoneum, they can cause a pneumoretroperitoneum. Okay. The next place to think about abnormal gas is in the wall of the bowel itself. So pneumatosis, okay? Here is an example where someone's got florid pneumatosis, which when you first see it can be tricky to appreciate on an abdominal x-ray. But when you see this kind of bubbly pattern overlying the path of the bowel, so everywhere that we look here, over the path of the bowel, then we've got this kind of bubbly pattern. And then if you look down here, you can appreciate there's actually gas in the wall, in the very edge of the bowel itself. So this is pneumatosis. There are also signs of pneumoperitoneum here indicating perforation. So I think that there is a kind of vague wriggler sign here. And then that triangle we talked about, the telltale triangle sign, there's a little triangle here in the right upper quadrant. So if we go to this person's CT, then obviously it's way clearer. So if I scroll through these axial images, there's actually gas here within the liver, which is not biliary because it goes all the way to the periphery. So this is portal venous gas. And then we've got a large pneumoperitoneum, all of this free air anteriorly. And then everywhere you look, there's gas in the wall of the bowel. Okay, so this is essentially frank necrosis of the bowel with gas in the bowel wall, pneumatosis. That gas then escapes into the portal venous system. And then that ends up in the liver. So this is a pretty bad CT to have. And then you can also see this is the falciform ligament, and you've got lots of free air around it as well. So remember, gas in the bowel wall. And then the kind of final area that you might see gas is in other structures, and really the main one to be aware of is gas in the bladder wall. So here it is in the pelvis, and you've got gas which is all the way around within the bladder wall. So this is known as emphysematous cystitis. This is not necessarily cystitis as in infection cystitis, and this is frequently seen in diabetic patients, and sometimes you can also see gas then extends up to involve the ureters and the kidneys as well. So if you see this, make sure you look up in the region of the kidneys to check there isn't anything there. So that's everything to do with the air, pneumoperitoneum and pneumoretroperitoneum, and don't forget pseudo-pneumoperitoneum, air in the bowel wall, air in the bladder wall as well. Now we'll think specifically about bowel itself. So the B in abdo-X is for bowel. And we'll start off by first trying to understand how we differentiate small and large bowel and how we pick up small and large bowel obstruction. Okay, so the small bowel is located centrally and has got the valvulae convergentes that run all the way across the diameter of the bowel. So these are the lines, the folds that run all the way across. Okay, and they're frequently and regularly spaced. And this bowel is located centrally, so this is small bowel. And then in terms of knowing whether it's dilated or obstructed, you'll have heard of the 3-6-9 rule, which is that the upper limit of small bowel is 3 centimeters, large bowel is 6 centimeters, and the cecum, which is the most capacious part of the large bowel, is 9 centimeters. Now, I teach that to the medical students, but I emphasize to them that as radiologists, none of us are getting our calipers out and measuring the small bowel or the large bowel, or certainly we should not be. So if you see that happening, tell the person to stop, because defining obstruction is a lot more than just looking at the measurement. So if it's 2.9 centimeters, I'm not going to say, well, this is not obstructed, because it depends on the morphology, the distribution of bowel loops, whether there's an abrupt transition point, whether there's mesenteric free fluid, whether the clinical history fits with obstruction. So it's a lot more than just saying an absolute number. And when small bowel loops are distended and obstructed on an abdominal x-ray, it's much easier to appreciate the gas that's filling them than fluid. Now, we don't do erect abdominal x-rays in this country, but if you look at textbooks, if you watch online videos, you'll see other people describing them, and then you'll end up seeing air fluid levels because the small bowel is distended with air and fluid. But on our supine radiographs, which is how we take them, it's difficult to see the bowel loops which are filled with fluid because there's nothing to appreciate. It's difficult to appreciate them versus the background soft tissues. Whereas when they're distended with air, like you see here, then you can appreciate that. That particular case was because of obstruction at a midline hernia. This is actually someone who had recent laparoscopic surgery, and this is one of the port sites, and a little bit of bowel has been caught in there. And so it's causing obstruction of all the small bowel upstream from it. So on a CT, you can appreciate far better how much of the small bowel is distended, whether it's fluid or gas filled, whether or not, where the transition point is, and whether there are any complications such as mesenteric congestion in free fluid, which in the context of obstruction is a sign of mesenteric ischemia, or whether there's any perforation. Here is another example. So just to illustrate to you again, the valvulae convergentes, which run all the way across the diameter of the small bowel. You won't see all the small bowel distended. So here we've just got a cluster of loops here on the right side of the abdomen, but that this, in the correct clinical context, would fit with small bowel obstruction. Okay, so here's a zoomed up view that just shows these folds that run all the way across a little bit better. Okay, so now let's look at large bowel obstruction. So large bowel obstruction sometimes is difficult to appreciate as easily as small bowel obstruction, because often large bowel and small bowel obstruction occur concurrently, and so there's a lot going on the abdominal radiograph. There's dilated small bowel and large bowel, and that makes the picture confusing. But here I want you to concentrate on this bit of bowel that runs around the edge on this right side, and then we go up to the top, and there's another loop here. And so this is the ascending transverse and descending colon, which are distended. And if you look at the folds, we have lines that run part of the way across the diameter. Okay, so these run part of the way, not all the way across. So those are the haustral folds. They're different from the small bowel valvulae conjuventas, and they differentiate small from large bowel. And the large bowel frames the abdomen, so lies around the periphery of the abdomen. So those are the key differentiating factors. Okay, so the small bowel is central. Look for those lines that run all the way across the valvulae conjuventas, and it contains air or fluid, air being much easier to detect on an abdominal radiograph. The large bowel lies peripherally, contains haustral folds which run only part of the way across, and may contain air or feces. Air is air, feces is when you get this kind of bubbly, mottled appearance to the content of the bowel. Now, that large bowel obstruction was because of a stenosing tumour of the mid-descending colon. So that's where there was an abrupt transition. There are two specific other patterns of large bowel obstruction you need to know about, the two different types of volvulus. Okay, so the first one is a sigmoid volvulus. Now, there are heaps of different radiographic signs that you'll come across talking about volvulus, sigmoid volvulus, and there is a lot of overlapping appearances. The key thing is you have a single grossly distended gas-filled viscus which occupies much of the abdomen and pelvis. It may point to the right, it may point to the left, it may point just straight upwards. It varies. You may or may not see a convincing coffee bean sign. Not really seeing a convincing one here. But really importantly, look for the normally positioned cecum and ascending colon, like you see here. We've got the cecal pole over here with some gas within it and some fecal matter, and then the ascending colon here running up to the top. Okay, so it's overlapping the edge of this distended viscus. So that means that the cecum and ascending colon are in a normal position. So this cannot be cecal volvulus. So this has got to be sigmoid volvulus. Very helpfully, there's no gas in the rectum, so that indicates it's a soft sign that there's an absolute obstruction. Of course, CT makes the whole thing much easier. So if you look at the CT, you can see that there is a twisting here, the swirl sign of the sigmoid volvulus. If we look at the coronal, can you see this kind of whirlpool sign? So this whirlpool, where you got the vessels twisting around in a circular fashion around the fat, indicates that's where the twisting is. So that helps to confirm that this is sigmoid volvulus. So then the other one is cecal volvulus, which is this one. So you've got, again, a gas-filled distended viscus, not as large as with a sigmoid volvulus. And the thing to notice on this one is that you should have on the left side a normally located descending and sigmoid colon, which confirms for you that this is not sigmoid volvulus. Now, with cecal volvulus, depending on the status of the ileocecal valve, i.e. whether it is competent or incompetent, you may then have additional small bowel obstruction if the gas can reflux into the small bowel. As you see here, you see in the right lower quadrant, we've got gas-filled distended loops of small bowel in addition to this, which is the distended cecum. And again, CT makes it easier. So we see that this is the cecum here, and then here we've got the ileocecal valve, which is open, and so you've got gas refluxing into the small bowel. And then the twist in a cecal volvulus is actually of the proximal ascending colon. And as a result, it's the cecum that then becomes very distended. But the twisting itself is around the proximal ascending colon. And again, you can appreciate there's a kind of swirling appearance to where the twist actually happens. All right. So the next thing with B for bowel is the bowel wall. So in A section, we talk about air in the bowel wall. In this section, I want you to think about thickening of the bowel wall. And really, we're focusing more on the large bowel than the small bowel when it comes to thickening. And with the large bowel, the kind of pattern we get is something called thumbprinting. So thumbprinting is what you see here, which is the bowel wall, the haustral folds are very thickened, and it looks like someone's come and put a thumb on the edge of the film, and that's the kind of picture you get. And we see that in a couple of different places. Now that's a very non-specific sign of colonic edema. It doesn't tell you what the edema is caused by, whether it's infection, ischemia, some other kind of inflammatory bowel disease. It just tells you that there is edema. And here we see it running all the way along the transverse colon. So it's quite a long length of colonic wall edema. In this case, we have superimposed colonic wall edema, but also what's known as the lead pipe colon sign, which indicates that now this colon has undergone many cycles of inflammation and has begun to lose its haustral fold pattern and it's effectively become burnt out colitis. So in the transverse, we have some undulation of the colon contour indicating there is some edema, but then along the descending, we're now beginning to just see straightening of the bowel wall with no normal fold pattern, and that's the lead pipe colon sign, which indicates essentially chronic colitis. And then finally, with B, I want you to just think about the position of the bowel. Okay, and this is a very difficult call on an abdominal X-ray to make, but you need to look at the position of the bowel and how far to the edge of the abdomen the bowel extends. Now, it should extend quite far to the edge, and you should also see a stripe of fat between the edge of the bowel and then the abdominal wall. This is known as the properitoneal fat stripe. In this example, just note how the edge of the bowel here on the right side is quite a way in from the abdominal wall, same on the left side. And also look how hazy the appearances are along the sides of the abdomen and in the pelvis. Everything looks like it's kind of a washed out grey appearance. And this is because of ascites. Okay, so this is a supine radiograph. There's fluid in the abdomen, just like you get with clinical examination, the shifting dullness sign because the bowel is all floated centrally to the top. You've got the same appearance on a radiograph. You've got the same finding. You've got the bowel loops which are moving in centrally because they're floating on top of the abdominal fluid, and so you see them far away from the edge of the abdomen, and all of this haziness is because of the ascites. Now, obviously this is a much easier diagnosis to make if you have an ultrasound or a CT. Alright, so we'll move on to the next bit, D. So A and B were really the big bits with regards to bowel and bowel wall gas and bowel obstruction. Okay. Now D is for densities and other areas of calcification. So there's a number of different calcified structures that you can see on an abdominal radiograph. Now let's put gallstones to bed straight away, because we know that the majority of gallstones are not seen on X-ray or CT, which is why we use ultrasound or MRI to detect gallstones. But with kidney stones, the majority can be seen on X-ray or CT imaging. Now, this is a really gross example of a staghorn calculus, filling most of the pelvic ileal system of the left kidney. So those are relatively easy to see. Smaller stones can be difficult to see on abdominal X-ray, and we know that CT is far superior in picking them up. You might also sometimes get this situation where you've got a stone here in the lower pole of the left kidney, so that's a sizable stone. But also note this, you've got this row of stones here in the distal left ureter. And this is after this patient's undergone some kind of therapy for a larger stone, such as shockwave lithotripsy, to enable the stone to be broken up into small pieces. And this is an expected complication, effectively, where those stones then break up and then pass down the ureter towards the bladder. And when you have a row of stones like this in the distal part of the ureter, this is known as the Steinstrasse sign, which is a German phrase which means stone street, because you see essentially a row of stones in the ureter, a bit like the stones placed for a stone street. Another structure that can become calcified is the peritoneum. Again, we don't see this very commonly. So here, what we've got is this kind of diffuse, along this side linear, quite thick, heterogeneous kind of calcification, and on the left side here it looks more patchy and amorphous, and it doesn't really follow any particular organ system, right? This is not the outline of the liver or the kidneys or the spleen. So when you've got this kind of calcification which spreads along a wider area, doesn't conform to an organ system, it's a bit blobby and amorphous, think about peritoneal calcification. Now in adults, there's a couple of different contexts in which you might see this. One is when, with certain types of malignancy, when they've undergone successful treatment, they can leave calcification. So I'm thinking about ovarian peritoneal metastases, they can calcify. And then the other thing is calcification as a result of long-term peritoneal dialysis. And this is known as encapsulating peritoneal sclerosis. And what you get effectively is a like a shell, a cocoon formed. And that's one of the various phrases that you'll hear describing this, which is peritoneal cocoon or abdominal cocoon, because the peritoneal space becomes calcified, becomes a shell. The surface of the mesentery can become calcified, and the small bowel is not very mobile. These patients kind of suffer from a form of subacute kind of chronic bowel obstruction. And when you do the CT, you'll find that there are some dilated small bowel loops. This is not like a proper mechanical small bowel obstruction, but you might see that as a complication of peritoneal dialysis. You're likely to come across this as an exam film, to be honest with you, also when you do your 2B exams, because lots of examiners will still have this kind of example in their collections. Abdominal aortic aneurysms, or just, abdominal aorta and iliac arteries, whether aneurysmal or not, can be calcified. In this example here, we've got calcification of an aneurysm of the abdominal aorta. So you may well see this as an incidental finding. And then also this kind of calcification here, which is of the costal cartilages of the ribs. Okay, it can look a bit alarming the first time you see that, but this is just kind of irregular calcification of the ends of the ribs. All right, so then we'll move on to the O, which is for organs and soft tissues. Now, we absolutely do not do abdominal radiographs to interrogate the organs or soft tissues, because it is way too much of a blunt tool to be able to do any effective analysis of those organs, soft tissues. And that's why we do ultrasound and CT and MRI. But when you're looking at abdominal radiographs, you will notice organs and soft tissues, and you may well pick up incidentally some kind of abnormality. And the reason we can see the organs and soft tissues is because of their outline, and more specifically the fat that outlines the organs, which allows you to differentiate it from the adjacent structures. It's about tissue density, like we talked about before. So here, along the edge of the liver, this is fat, and that allows me to define where the liver is. I can make out where the kidney is, because look, just around the kidney there's a bit of fat, so I can see the edge of the kidney on the left and right side very clearly. Now, this is an example of a liver that's slightly enlarged. You've got the right lobe, which comes all the way down here to well below the iliac crest. So this is a Riedel's lobe, which is an anatomic variant of an enlarged right side of the right lobe of the liver. But this is a nice example where you also see normal kidneys, and then also in the left upper quadrant you see the normal spleen. Okay, because the soft tissue of the spleen itself is more dense than the surrounding lower density fatty tissues. That was a normal spleen. This is an enlarged spleen. So you note here where now the splenic tip comes down here just above the iliac crest. Okay, so this spleen has come out of the left upper quadrant, come well below the costal margin and pushing down here. This doesn't tell me anything about what's going on in the spleen, whether it's full of lymphoma deposits or whether it's just homogeneously enlarged because of some other cause of splenomegaly. So it's quite a blunt tool to tell us what's going on with the organs. Okay, and then with that we'll move on to the final bit, which is the X. Really, the X is for everything else, all the foreign bodies, all the various iatrogenically placed bits and bobs that you might find on an abdominal radiograph. And there's a whole heap of medical devices that you'll find. So here is one. This is a capsule, this is a patency capsule, which is related to capsule endoscopy. So this is not the actual proper capsule endoscope. This is one that's given as a test to see whether or not there is a small bowel stricture and whether or not it's safe for them to proceed to administering a proper capsule endoscope, because this is bioabsorbable, so there's nothing metallic in here, and this can disappear. So if you are reporting abdominal radiographs from the gastroenterology clinic, you'll often find these kind of structures on there. Another one is a peritoneal dialysis catheter. There's still a lot of patients who have them. They'll often request abdominal radiographs if there's some kind of problem with the dialysis. maybe ineffective dialysis, just to check that has there been a fracture of the tubing, is it still appropriately placed within the abdominal cavity. So you will see this kind of tube which is variably located with this curled ending within the abdominal cavity somewhere. Another specific use of abdominal radiographs is to look at abdominal vascular stents. Okay, so aortic and iliac stents. You can see here this person's had an EVAR. They've got these stents placed, and there'll be a regular follow-up regimen for these patients to check whether or not there's been perhaps migration or some kind of fracturing of the arms of the stent. And then you'll also see other devices within the thorax, such as pacing devices and pacing wires and sternotomy wires as well. Now, another thing on here is just going back to D. D was about calcifications. Okay, so we looked at kidney stones and ureteric stones, calcified peritoneum and aneurysm. D is also for bones as well. Now, there's a lot of bones on an abdominal radiograph to analyze. You've got the whole of the lumbar spine and the iliac bones, and then all the usual bony diseases that you see elsewhere, you'll pick up here. So here we've got incidental Paget's disease of the left hemipelvis. You can see that there is trabecular thickening and coarsening of the pattern here compared to the right side. So we've got features of Paget's disease. So don't forget to analyze that when you're thinking about the D in AbdoX. Another indication specifically for plain film is location or localization of intrauterine contraceptive devices. So if at clinical examination they can't find the threads, and then at ultrasound they can't see the IUCD within the uterus, then they'll ask for an abdominal X-ray. And this is the kind of thing you'll see. It's placed in the midline. Its orientation varies depending on the orientation of the uterus, which you can't tell on this radiograph. And this is an example where they couldn't see it at clinical examination. They couldn't see it ultrasound, and on the abdominal X-ray, it's up here. It's in the left side of the abdomen, and you're seeing it from the side in profile view, which is why it's got this appearance here. If we did a lateral, then you'd see the T shape. Anyway, they couldn't find this at laparoscopy, and they placed a new IUCD in the uterus, and they, for some reason, requested a repeat just to check, well, where is the other one? So in fact, it's still there. And now you can see it slightly moved, so you can see the arms of it, and then this is the one in the pelvis that's successfully placed in the uterus. But because there's no clinical consequences, patient wasn't suffering from inflammation or abscesses. They've just left this in. Now there are two more important specific contexts where we use abdominal radiographs now, which I'm going to talk about. So the first is a water-soluble contrast challenge. Now, this is sometimes known as the gastrographin challenge. So this is both a therapeutic and diagnostic procedure done for non-complicated small bowel obstruction. Okay, so uncomplicated small bowel obstruction means someone is diagnosed with small bowel obstruction, likely due to adhesions, without any radiologic or clinical features of ischemia or perforation, and where clinically they're stable and it's felt safe that they can wait 24 hours to follow a conservative regime before the need to intervene is then considered. So here is an example of someone who's got small bowel obstruction. I'm not going to go into the details of what we're seeing on the CT because you can have that covered in other lectures, but we've got lots of dilated fluid-filled loops of small bowel. Right at the top you saw the stomach was distended, and then down here in the pelvis you've got this bubbly appearance to the content of the small bowel. So this is known as the small bowel feces sign, because this matter is said to look like the feces that you normally see in the large bowel. And this is a sign of stasis, and it's a sign that the transition point is somewhere near here. And you should always analyze these on multiple different views. So always make use of your coronal and sagittal reformats. So anyway, this is the transition point near here because the bowel beyond this is all collapsed to the level of the terminal ileum. So we're happy that this is an adhesional small bowel obstruction with no complications such as perforation or ischemia. So this patient was then given gastrographin, and then this radiograph was taken 4 hours later. So the gastrographin is administered on the ward. 100 milliliters is administered, and the timing of the radiographs varies, but roughly speaking, the first one is done at 4 to 6 hours, and then a second one, if the first one shows there is still obstruction. The second one is done at 24 hours. And that should be it. No more after that. Because if at 24 hours there are still signs of obstruction, that patient then needs to be escalated for operative therapy, not continue on a conservative management pathway. So this one was taken at 4 hours, and at 4 hours what we see is that we've got little bits of contrast here within scattered everywhere across the abdomen, but it's gone through to the large bowel. That's the important thing, that this shows that there is no ongoing absolute small bowel obstruction. So if we track it, on the right side, it's all along the ascending colon, and then down here, the transverse colon, all the way down to the sigmoid, okay? We're not seeing it quite in the rectum, but it successfully passed through into the large bowel. So this is what's known as a successful water-soluble contrast, or successful gastrographin challenge. Let's look at an example of a failed or unsuccessful challenge. This is a different patient, radiograph taken 2 hours after gastrographin, loads of dilated loops of bowel, filled with gas and filled with the gastrographin. And look, you can see those valvulae convergentes really nicely here running all the way across. Then another radiograph at 24 hours. Remember, this is the deadline. If it hasn't gone through into large bowel on this radiograph, the patient could be in trouble. And look here, the small bowel is still significantly distended. The contrast has gone through a little bit further into small bowel, but it just fills those small bowel loops. It hasn't gone through into the large bowel at all. I can't see the cecum or ascending colon or transverse colon. So this is a failed or unsuccessful water-soluble contrast challenge. Now, sometimes there can actually be a technical failure. This is not really appreciated as much, I think, as it should be. So what is recommended is if a patient's got a nasogastric tube in, which they likely will if they've got small bowel obstruction, then the tube needs to be clamped for a couple of hours. Sorry, the tube needs to be left on free suction for a couple of hours to empty the stomach. Then the gastrographin can be administered via the nasogastric tube if necessary. And then the tube needs to be clamped for an hour so that that gastrographin is not immediately sucked back out. And hopefully in that hour, some of it then goes through into the duodenum and into the small bowel. But what happens is if you don't clamp it and there's continuous free suction, it'll just come out and it won't have gone through. And then the test is essentially rendered useless. So this is the first film taken at 6 hours with this gastrographin within the stomach. It's not gone through into the bowel at all. And then the patient continued to have features of obstruction. Now, no more gastrographin was given, but they requested films at 72 hours. So clearly the patient must have been clinically not sick enough to go for theatre, but they were concerned. And we see the nasogastric tube is in situ, but the stomach is empty, but in fact so is the rest of the bowel. Now, there's two possibilities, right? One is that the gastrographin in 72 hours has made its way all the way around and left completely, including all of it passed out the large bowel. Or what I think is more likely, which is actually most of it was suctioned out by the nasogastric tube because of the ongoing vomiting that the patient was having. And in fact, nothing's gone through at all. So really, there's no more comment you can make about this. And then finally, there is a soft indication of differentiation of ileus versus mechanicum obstruction. And there's not enough data to recommend this as a definite indication. So here's an example of someone who came in with acute appendicitis. So right iliac fossa coming off the cecum. We've got the appendix, which runs here medially. It's very thick-walled and distended, and there's lots of inflammation around it. Okay, so a nice simple example of uncomplicated acute appendicitis. And then the patient had a subsequent CT because they weren't recovering, and there's some distension which showed vague distension of much of the small bowel, no hard transition, bit of free fluid. So they gave a gastrographin challenge, and 6 hours after administration, what we see is that there is some contrast within dilated small bowel loops here on the left side. But also it's gone through into the large bowel. Okay, so here, this is the descending colon, which is filled with a contrast running all the way down here towards the sigmoid and look all the way down to the rectum. So we know from this that there is no hard transition point with no absolute obstruction, and the contrast has managed to get through into the colon, but there are still some distended small bowel loops. So does this really help us? Because this could be still like a subacute bowel obstruction, or it could be an ileus. And because we don't really know exactly what it is, it's difficult to advocate too firmly for this test. But sometimes they slip through the net of vetting, and they're requesting them and acquiring them. And then the final clinical scenario I want you to be aware of is the use of abdominal x-rays for colonic transit studies. Now, these are outpatient studies requested by the gastroenterology team to look for slow colonic transit. So there are lots of different protocols that are used all over the world, depending on what they actually administer to the patient and what the evidence is for that particular type of material. So we give them a capsule that contains 20 small radiopaque markers, and they have x-rays taken on the first day and then day 5 as well. So this is typically what the day 1 x-ray looks like. You've got the markers that are clustered here in the right lower quadrant of the abdomen. Difficult to tell whether this is distal small bowel or cecum, but that doesn't really matter. The important one is the day 5 x-ray, on which you see none of the markers. Okay, so that indicates that there is no impairment of colonic transit, despite the fact that this large bowel has got solid fecal matter all the way through it. It's still appearing to transit the markers at an appropriate time point. Now, one other thing just to show you on here, linking back to what we saw in our previous parts of this talk, which is I want you to look at this very well-defined structure here in the pelvis, which is got gas density. Now, this is the appearances of a vaginal tampon that you see on an abdominal radiograph, okay? Because it's low density, so that's the kind of appearance you'll have. And here is on the day 5 in a slightly lower position, so just be aware of that finding. So that was a normal colonic transit study. This is an abnormal colonic transit study. So this is the day 1 x-ray. We've got markers which are a bit more widely scattered on this occasion, and again loads of solid fecal matter, much more than the last one, all throughout the large bowel. And then on the day 5 x-ray, you can count them, but essentially most of the markers, if not all of them, are still in the abdomen, ranging from the proximal descending colon up here, okay, all the way down, and then most of them here scattered in the pelvis, in the sigmoid. Now, the guidelines are that to label or diagnose impaired or slow colonic transit, more than 20% of the markers have to be present on the day 5 x-ray. So essentially, if you've got 4 or more, then I report it as impaired colonic transit. And clearly this is very abnormal because pretty much all of the markers have been retained. Okay, so that's everything I want to tell you about abdominal x-rays and the AbdoX system. So my kind of takeaway important messages are: first, let's really think about the place of abdominal x-rays in modern acute abdominal imaging. And for most situations, such as question mark perforation or collection or bowel obstruction or ischemia, CT is the modality of choice. There are still many situations in which we do abdominal radiographs, and we've run through a few of those. Please be aware of the appearances of small and large bowel obstruction and how you differentiate them. How you look for bowel wall gas, pneumoperitoneum, pneumoretroperitoneum, and then the appearances of all the different kinds of iatrogenically placed foreign bodies that we see on radiographs, either incidentally or whether we are specifically looking for them, such as the capsule, intrauterine contraceptive devices, and the different vascular stents. Okay, thank you.